And what we're doing today, this is the Appropriations Subcommittee on Public Safety, and we are dealing exclusively with the 2013 amended, and we're going to hear from corrections today. We have no intention to have any other hearings on the 2013 amended. We have been talking with some of the other agencies, think that we can deal with most of the issues that we've got without having formal hearings on those. Now, when we get to the 2014, because we will be talking about a full 12-month cycle as opposed to probably 3 months by the time this budget is signed, that we will be having hearings with a lot of different agencies, but not all of the public safety agencies, because quite frankly, some of them either have one issue or maybe two issues or no issues, and so there's really not a need to have a full-blown public hearing. It's just a matter of trying to understand the issues and deal with them. But today, and we're not singling you out except for the fact that as we have previously yes, you as we have previously advised, we're looking at perhaps a small cut in health, and but we wanted to talk to you all about the health program and maybe see if there were a more appropriate place, or whether you wanted to spread it around across several programs. Okay, so you and Becky, or what? Yeah, well, I want y'all at the mic so that it will be. As we told you, Commissioner, the couple of things that we wanted to talk about, and of course, you know, we wanted y'all to be prepared for that, so we sort of gave you a heads up. If some of the other committee members want to talk about some other issues, then, you know, if you feel comfortable in answering the questions, fine. If not, just get us the information later, or we'll talk about it when we get to the 14.
If we can answer today, we'll answer today.
Yeah. First of all, talk to us a little bit about Bostic, and the reason, I mean, I understand what you said, but I was sort of taken by surprise when you said that y'all had turned the money back in. I knew it wasn't moving as fast as y'all had hoped, but I did not know y'all had given up on the project. And so if you'd give us a little bit more information on that, because last year when we talked, it was, you know, a question about whether we were going to do a private provider, whether we were going to do a separate location or a state-owned location, but there never seemed to be a question about that it made a good business sense to do this, so that we could parole these people into a facility and then they would be able to get Medicaid dollars. And that the reason this facility were chosen, because it met all the parameters that you have to meet as far as, you know, how many feet you got to be away from this, that, or the other when you're dealing with sex offenders. And so the fact that you've abandoned that's come somewhat of a surprise, and so we'd like for you to address that a little bit, if you will.
If I could, Mr. Chairman, give a little bit of context and background to those members of the committee who may not be as familiar as you clearly are with the issue. As you know, we've embarked over the last 6 to 8 years on closing some old inefficient facilities across the state, and we replaced that capacity with fast tracks and private prisons. So we have the prison capacity there. One of the facilities that we closed down, one of the 4 that we closed down in Milledgeville, was the old Bostic State Prison. Bostic's history was, its origin was as a nursing home for Central State Hospital for many, many years. And then during the late 70s, early 80s, some of those old facilities in Milledgeville were converted to state prisons. Well, as we progressed, we realized that those are not efficient facilities. Obviously, with modern-day infrastructure, modern-day technology, if you build a prison from the ground up today, you could staff it with a third to a half of the people that an old mental health hospital would be required to do. So we shut that facility down, along with 3 others in Milledgeville. One of the problems that we've had over the years, and it's not unique to Georgia, all correctional settings across the nation, is escalating health care costs. that are mandated by the United States Constitution, and we provide health care to inmates at a constitutional level. So we're always struggling with the fact, just like the civilian world, that as an inmate, or you or I in the civilian world, gets near the end of our natural life, that's when the hospital bills go up dramatically. So we were at a point several years ago where our top 200 sickest inmates were costing us about $25 million per year. That's 200 out of today's 57,500. Again, it's not a unique phenomenon. Happens in the civilian world just like it does in the prison world. So we were looking for some alternatives to try to reduce the cost to taxpayers of providing that health care. Obviously, if we provide health care in a prison setting, the state taxpayers are on the hook for 100% of that health care cost, state taxpayers. And our health care costs, as we talked about at joint appropriations, we do by and large now have under control. So we were looking for a way out. So we took a look at Bostic. We felt that we could rehabilitate that using inmate labor, mobile construction, and then partner with a private service provider who would operate the facility using Medicaid funds only. Obviously, state taxpayers would still be on the hook. I think it's 33%. Is it 33%? State taxpayers would still pay 33% of the cost of the health care, but the other 67% would be spread across the federal level. So working with our partners who do have the authority to release, obviously corrections has no authority to release. Only judges, the parole board can release. We have no control over who comes in either, obviously. We just house them for as long as the judge or the parole board tells us. Working with our parole board partners, we thought that population might be large enough several years ago to allow the state to invest the $6 million into Bostic and then turn it over, lease it essentially, to a private service provider for the Medicaid, to receive the Medicaid funds to operate that facility. So there would be no direct Department of Corrections or tax dollars directly geared towards Bostic. As we got closer and closer to the project, the funds were appropriated, as you recall last year, cash funds. As we got closer and closer to the project, working with our various partners to try to determine whether or not we had a large enough population that could be paroled. And critically, you mentioned the critical part, the beauty of Bostic was it's not within 1,000 feet of anything other than other closed state prisons. There are no churches, there are no schools. So the sex offender provisions would not prohibit placement in this facility for these type of offenders. But when we got right down to it, ready to negotiate a lease contract with a private service provider, looking at the population, it was determined that we did not have sufficient numbers in the prison system to parole to this facility to make it a viable business for the private service provider. So we uncovered all the stones, looked in the cubby holes, and we just could not provide the numbers necessary to operate that as a viable business. So at that point, after 3 years of work on the project, at least 3 years of work on the project, we abandoned the project because it just was not a viable business opportunity for the vendor. Hate to admit defeat, but that's what happened.
Well, I'm speaking for myself. I appreciate the fact that you are looking under the rocks for ways to save money because, as I understand it, out of your $1.1 billion budget, that roughly $200 million is health care costs.
Yes, sir, that's correct.
That certainly is something that if there are ways to save, then we need to do that. And now that you have gone through that exercise and know what questions to ask and what numbers are needed to make that kind of project a viable project, then if situation changes, it's not like you've got to do 3 years to bring it back off the shelf and look at it again.
Absolutely. And there are a couple of fixes perhaps on down the road, Chairman, that we might want to take a look at, but it's a political fix. And if I may speak freely here among the members, I mean, it's just going out over the world. Go ahead. It's all right. It's all right. As long as my kids aren't watching on TV. There are some fixes. You recall, or may not recall, but back in 1994, we passed this legislation called the Two-Strike You're Out, Senate Bill 440, Senate Bill 441, the Juvenile Companion. And it limited or mandated that if you're convicted of one of 7 deadly sins, we remember that, Representative Green, we were together back then, that you must serve a mandatory 10 years in prison or at least 100% of the court order sentence. So you have to do 10 years on this offense. If the judge said 20, you got to do 20. If the judge said 50, you got to do 50. Truth in sentencing. Part of the provision of that statute was that in order to be eligible for a medical reprieve, and let me back up for a second, our partners at the parole board have been very good partners over the past several years on the medical reprieve process. In statute, the medical reprieve statute says that if we determine that this offender is nearing the end of his or her life, that we can refer this offender to the parole board to be considered for clemency, a medical reprieve. Years ago, that was very, very rare, but working with our partners in the parole board, that has become a more commonplace occurrence. Now, when I say commonplace, we're talking 1 or 2 a month. We're not talking 300 or 400. It's still a rarity that happens. But when we refer, their grant rate is about 50%. Now, we just don't throw this person out on the street. We've got the Medicaid lined up, and we've got the nursing homes lined up, and they go to a nursing home or a hospice to do that. As we speak today, of the 57,500 inmates in the Georgia prison system, over 16,000 are serving under this 1994 Seven Deadly Sin Law. Part of that statute said that in order to be eligible for a medical reprieve, the inmate must be entirely incapacitated. That is in the language. So the parole board, rightfully so, if we were to refer one of these 16,000 plus inmates, they must be entirely incapacitated according to the statute. Perhaps, Mr. Chairman, at some point in the future, this body may consider altering that language to allow more flexibility in that. But that's something that we've taken a look at, and it does require legislative change to do that, to make more inmates eligible. And a common phenomenon that we see is that you may have had a sex offender who 20 or 30 years ago committed a sex offense, but today he's an Alzheimer's patient. He doesn't know where he is, let alone what he did 30 years ago. So we're bearing 100% of the costs of that particular individual. So that may be something in the future that we discuss.
But entirely incapacitated under the interpretation of the parole board is because he's physically mobile, even though
Yes,
he's lost his mind,
Yes,
that
sir.
he is not entirely
Yes, sir.
incapacitated.
Yes, sir.
In other words, you almost got to be in a vegetative
Yes,
state
sir.
to meet that criteria.
Yes, sir.
Do you have, is somebody from parole here? If y'all would get together before we do the 14 hearings and maybe come up with some suggested language, maybe, I don't know, talk to somebody in the governor's office too. But I think that might be something that we might be interested in as far as maybe an extension of the criminal justice reform, and we can talk to some of those folks about that. But that seems to make a lot of sense. So, we would certainly be happy to work with you on that and talk about that.
And with a $200 million appropriation, every day we're looking at ways to try to control those costs.
Okay. All right. Any questions that anybody has about Bostic medical reprieves or anything before we use that as a segue into just talking about health in general? All right. If not, then let's talk. You said, you gave us some numbers and some figures in the joint hearings and talked about the things y'all had done in addition to the medical reprieves as far as trying to control health costs and what y'all had been able to do. And would you talk to us a little bit more about that and flesh that out? Because I remember hearing an 8-point-something% decrease. And so anyway, I'll talk about that and what y'all have done.
Yes, Mr. Chairman, we're actually very proud of that. We have been, as 3-4 years ago, we commissioned Deloitte to come take a look at our healthcare costs and our healthcare process and rack and stack us, if you will, against some other states who are willing to provide the data. Some states are not willing to provide the data. But we can get you a copy of that report. It was an eye-opening report several years ago that shows that the model that we're operating in Georgia is a very efficient model, producing good outcomes as opposed to some of our colleagues in the southern states. I believe I got that to you a couple of years ago, but to refresh, Becky, if you wouldn't mind, make sure the committee gets additional copies of that. And they made some specific recommendations, and I've got to give this body a lot of credit. We brought it to the House several years ago, and some House members sponsored some legislation that really helped us bend that cost curve down. One of the things that was happening out there, you can imagine, again, 57,000 inmates. We're working with local hospitals, and when it came to emergency care, we were essentially paying the retail rate for emergency care. Never really made much sense to me. We're responsible for probationers on the street and prisoners in the prison. If a probationer on the street's playing basketball and he breaks an ankle, he goes to the hospital, who pays the bill? Medicaid pays the bill. If that same probationer gets revoked, goes in state prison, breaks his other ankle playing basketball, who pays the bill? Department of Corrections, through direct appropriation. So we came to General Assembly, y'all passed legislation which gave us the authority to cap emergency room care at a Medicaid level, but did not preclude us from negotiating for better rates, which was key to that. So that actually got the hospitals to the table then, that we don't want you just paying Medicaid rate for your emergency room care. And we said, we're fine with that. We'll pay above Medicaid rate, but let's talk about a contract rate for our planned procedures. So that enabled us to really tamp down the contract rate. So in most cases now we're paying for emergency care at Medicaid plus a certain percentage, fair to the hospital, fair to the Department of Corrections, and we're keeping our costs down. Several years ago, we took a look at what are the most frequent consults that we're taking an inmate, putting him in chains, putting him in a vehicle, taking him to a hospital or doctor's office to get a consult done. And we found that outpatient orthopedic surgery was a frequent consult, numbering in the thousands. So we partnered with a firm out of Florida, and we put a mobile surgical unit inside the wire at Georgia State Prison. Georgia State Prison, maximum security prison, we can handle any inmate there. So now if an inmate needs an orthopedic procedure done, instead of putting him on in a van, put 2 correctional officers, take him to the hospital for 2 or 3 days, get a procedure done, take him back to prison, we put him on a bus to Georgia State Prison. He does 1 day worth of pre-op at the prison. We wheel him out to the mobile surgical unit right there on the yard at GSP. The orthopedic procedure's done. He's wheeled back 1 day of post-op, right back on the prison bus to wherever he came from, saving thousands and thousands of dollars in the process. 3 years ago, we went tobacco-free in the Georgia prison system, although, and we talked about it 3 years ago, could we project savings? No. We know that there are some savings there because they're not using tobacco. But we went tobacco-free, and we know over the years that will pay us dividends as well, that the inmates are not using tobacco. We put a copay on pharmaceuticals. Oftentimes in a prison setting, what an inmate wants to do is he wants to go see a pretty nurse rather than an ugly correctional officer on a work detail. So he'll put in a sick call slip, go see a nurse, get some pharmaceuticals, whatever it may be, Advil, whatever the case may be. And he's laid out of a work detail, got to see a pretty new nurse, and he's got some drugs on the side. Well, we put a $5 copay on that. Now, if you're a chronic inmate, chronically ill inmate, you have diabetes or you have some kind of chronic illness, there is no copay. If it's a legitimate medical issue, a broken bone, a disease, or if you're mentally ill, or if you're indigent and have no funds on your books, there is no copay. But we did introduce a copay to try to drive those pharmaceutical demands down, and that has worked. Last year, and if I'm getting too far down the weeds, Chairman, let me know. Last year, working with our partners, Georgia Regents University now and Georgia Correctional Healthcare, and our model of healthcare is we partner with Georgia Regents University. There's a group in between called Georgia Correctional Healthcare that kind of work for both entities. They're the ones that are doing the contracts with the hospitals and doing the utilization management and make sure the right procedures are being done. But last year we worked with them to get some very, very special pharmaceutical pricing for our HIV population. It's called 340B pricing, if you're familiar with that model. Essentially what we did is we leased a piece of Augusta State Medical Prison to Georgia Regents University. Their docs come over, and everybody who's HIV positive in the Georgia prison system gets an on-site consult at Augusta State Medical Prison. That's driven our pharmaceutical costs for HIV meds down by roughly 50%, significant savings. We're on the teaching formulary for our pharmaceutical costs, which helps keeps our costs down. Utilization management, we opened up a what we call a immediate discharge facility right here in metropolitan Atlanta. Most of the major medical procedures that are long-term, expensive procedures are done at Atlanta Medical Center. Several years ago, we put a secure ward in there. Now, it may not mean much, but it means a lot to us. A secure ward means that we have 6 or 8 hospital beds that are secured in Atlanta Medical Center that we can staff with 1 correctional officer, 1 sergeant. If we did not have that secured ward, every inmate would have to have 2 correctional officers with him around the clock. So now that we have that secured ward there, most of our procedures are done there. We were tracking our hospital length of stay. If you're in the hospital business, one of the most important things is what's your average length of stay in a hospital. And we were averaging around 5.5 days length of stay in a hospital. As of last month, we were averaging 3.3 days length of stay. And it's about $3,500 a day per inmate on average to keep him in a hospital. Talking with the doctors, they didn't feel comfortable discharging a patient back to the prison system because they didn't feel the prison system had the medical requirements to make sure that post-op they were successful. So we essentially took a closed-down diversion center, made it an immediate discharge facility, staffed it with nurses and correctional officers. So now the very minute that patient inmate is ready to be discharged from the hospital, we're there to pick them up. So we've cut our hospital length of stay down by almost 2.5 days per hospitalization. So at every run, whether it's pharmaceuticals, whether it's contracts, whether it's consults, We're just trying to run that like a very, very efficient business. That's resulted in our per inmate healthcare cost decreasing between fiscal year 2008 and fiscal year 2012 by 8.1%. Decreasing. And that's just off the top of my head. I mean, we got more that we're working on.
That was 8.1% decrease between when and when?
Fiscal 08 and fiscal 12.
You mentioned on the medical reprieve some things that we could do to help you control cost and lower cost. In health, is there, just in health general, is there anything that we can do that will give you the tools you need to even get a better handle on it?
I don't think so, Chairman. We're currently working with, and that's a great question. Over the years, quite honestly, you've been very, very responsive. Every time we had a request, the General Assembly acts. Very, very responsive, and we appreciate that. As you know, and perhaps it's time to segue into the Medicaid hospitalization. We're currently working with the Department of Health. Some states, about a half a dozen states, have figured out a way, I know that's not very scientific, but figured out a way for certain inmates who are hospitalized at least 24 hours that Medicaid will pick up the cost of that hospitalization. We have been working with them for probably 18 to 24 months. Becky, I'm looking at you, about to get this done, and we're on the verge of making it happen. I think you, sir, asked the question about the progress of that, and I told you last week there were about 90 claims that are outstanding that we believe fits the Medicaid guidelines for reimbursement. And in fact, yesterday I confirmed there are 93 claims that are outstanding. To date, we have not received reimbursement. We're trying to work through that interagency and then state, federal morass, I guess, for lack of a better word, to try to get that done. We're hopeful that it's going to get done. It has not gotten done yet, but we're closer than we've ever been before, and we're currently working primarily with pregnant females, as I talked about. Medicaid says that they will pick up the cost if you were otherwise Medicaid eligible before you came in. If you're pregnant, blind, or aged, I believe is the other classification, if I'm not mistaken. So we thought we're taking the lowest hanging fruit. It's hard to deny if somebody's pregnant or not. Those are the claims that are currently outstanding. The majority of them are birth-related expenses. But to answer your question directly, sir, I don't think there's anything the General Assembly can do at this point to help us in that process. We just have to work through it.
All right. Well, let's talk a little bit about the Medicaid part, because and I'll be the first to admit that I know just enough to be dangerous. But my understanding is that when we first became aware of this in the General Assembly, it was because we were approached by a consultant who was looking for business. But they also said that if you can get the census of who's in prison, who might be Medicaid eligible, go ahead, get them pre-certified, that then when they're, and certainly you want to do that with those who are probably the more medically fragile, because you know that.
That's right.
But that if that treatment takes place outside the walls rather than inside the walls, and they have been determined to be Medicaid eligible, that then Medicaid will pick up those costs.
That's correct.
And that based on the results that had been experienced in North Carolina, Mississippi, and some other states, and based on Georgia's current population census in the prison, that we could be looking at somewhere between $10 million and $25 million or more in savings, just extrapolating based on Mississippi populations and North Carolina populations to reach some neighborhood of that. And in that discussion, it's my recollection that the Department of Corrections said, we think we can do this in-house, and so give us a shot at this before we start spending money on outside consultants, etc. And I guess my question is, have you gotten into it far enough to determine whether it's more than you can handle? Because in 18 months, if we're looking at, we've got 90 claims but no reimbursement, would we not have been better off if we had hired a consultant and had already generated some cash flow coming back in or some savings coming back in? Because we need a direction, but if we aren't going to be able to do it ourselves, then even if we have to pay somebody to manage this for us, I'd rather see us, collect 15 and pay out 2 or 3 or something like that than to, not pay out anything but only collect, $1 million or $2 million. So tell me a little bit about, let's just be straight about this.
Yeah, not that a consultant would ever exaggerate potential savings.
I understand that. You got to take all that with a grain of salt.
With a grain of salt, I concur with you. Obviously, if we can invest some amount of dollars in an expert to recoup some multiple of that investment, it's a good business decision. At this point, I still don't think an outside consultant is the answer. I think it's getting the two agencies to make sure that we're on the same page. Again, I don't know if that's the General Assembly's.
Do you want us to put you in a room together and not let you eat till you get solved? Or
we're in a room together already. It's just working through the hurdles. And if I thought, seriously, Chairman, if I thought I could spend if I could pay a consultant $1 million and get back $10 or $25 million, it's a no-brainer.
Yeah.
If I thought that could be done, I would do that in a heartbeat. But I just don't see that as being the issue. I think by the time you're out of session, we should have a solution in place.
The problem with that, though, is by the time we're out of session, if you don't have a solution in place, then we're looking at another year that we'll lose.
That's correct.
Okay.
I concur 100%.
Okay. Brian, you talked to Community Health?
Not directly, no.
Okay, but your understanding is they're waiting for an agreement to be signed or something?
There needs to be an agreement between the agencies.
Right, and DCH has that agreement in their legal office.
All right. Well,
Correct.
Let's do this. If you can, even if we got to bring somebody in from DCH when we do the next round of hearings on the 14th, let's get a little bit more feel for where we are, what the projected savings might be, what kind of timeline we're looking at, so that we can see where we are and, maybe even bring in one of these consultants and get them on tape telling us how much they can save us and how much they can realize. But we need to go ahead and move forward on this, because it is money that can help you in your savings.
We'll do that.
Okay. Then the last issue is we had told you that we thought that we were going to need, for the 13 amended, a cut somewhere in the neighborhood of $600 to $1.5 million. And it is going to be somewhere in the middle of that. It's going to actually be somewhere in the neighborhood of $700,000 to $1 million. But it's not going to be at the high end. It's going to be the low to mid-range. Tell me where you want to do that so that we can least impact you, whether it's in health or whether it's in prisons or where it is, or spread it out.
So the number you're saying is probably around 700?
700 to $1 million max.
Can we owe you that one, like within 24 hours or so? Let me go back, and I've seen the request. It said somewhere between $500,000 and $1 million. But we're covering a lot of things on our own already, Chairman.
I know.
And I know you know that.
I know.
And it gets to be a challenge even.
But I'm dealing with a $2.1 billion budget, and you're $1.1 billion of it. And so, the colonel's back there. If I told him that I needed $500,000 to $1 million out of his budget, he would probably pull his gun on me. And
you
I
did
know.
Ask us, by the way, how many of us are armed today? You recall before the.
I know I did. I did.
But I'll bet probably one of you is too, and I won't mention which one, but.
It's somebody to my right.
It could be, sir.
In more ways than one. All right, now, so you can do that within 24 hours. Let me explain to you the fiscal 13 amended is supposed to be on the floor of the House sometime next week, which means it's got to move out of this committee this week in order to go to full committee.
Understood.
And so I do need that within 24 hours.
Could I editorialize just a minute? Is that okay?
By all means.
And I will get that to you.
Sure.
Within 24 hours.
Sure.
We have built the fourth largest prison system in the nation. The fourth largest prison system in the nation. we have the largest per capita probation population in the nation. Every year, we pass new laws, not every year, many years we pass new laws. I already mentioned one in 1994 that has 16,000 inmates 20 years later in the system, costing not only dollars, but other issues as well. At some point, we've got to realize we've got to fully fund this thing that we've built. These 57,500 inmates and 164,500 probationers. Chairman, we haven't done that, and you know that. You know, we know that. We all know why, too. It's a tough situation. At some point, we've got to pay these correctional officers what they're worth. I'm not complaining. I'm just stating a fact. It's been a decade. A decade. $24,322 to work at Hays State Prison, Chairman Neal. $24,322.
We are very well aware of that problem.
Not as aware as I am.
What's your turnover?
26%. So that means when you walk into your prison, coastal, wherever it may be, 1 in 4 correctional officers have been there less than a year. The average correctional officer has been in service 3.5 years. You cannot run a prison system where your average correctional officer has served 3.5 years with a 26% turnover rate. Of the 8,000 correctional officers we have today, when we come meet next year, 2,000 will be gone. How can you operate a system with $24,000 a year? That's food stamp. That's food stamp wage. Chairman, you're chomping at a bit there.
Commissioner, that's a huge issue. My question is, when you look at prisons like Hays and Telfair, do you know at those specific prisons what the turnover rate there is? Because
sure.
I'm sure it's probably much more than 26.
For sure, it's higher.
Do you have that number?
Not off the top of my head, but I can certainly get by prison. I can certainly give you the turnover rate. We do track that.
I'd love to see that.
And the issue is, if we can hire, we can't retain.
Turn yours off. Okay.
At our close security facilities, we'll average any given day 30 vacancies, security vacancies. Now, what we try to do within our existing appropriation, as you know, Chairman, we'll try to scrape up a little bit of personal services money. We'll put a retention supplement, 5%. You may put a high security supplement, 5%, but we're self-funding those. And you do that for so many years, there's just not a lot of money left. Now, I'm not complaining or asking for a pay raise this year. I just want to kind of put it on the table that we've got a brewing crisis.
We're aware of it.
Brewing crisis.
We are aware of it.
In this state.
Tell me the number of correction officers.
About 8,000.
Okay. And what's the base salary?
$24,322. And I'm done editorializing, sir.
Well, that is something we need to know. We need to be aware of it. We don't need to get blindsided when it becomes a crisis. We need to be addressing it now. And certainly if the economy keeps turning and if the Medicaid does not eat us alive, which is where we are right now, is that all the agencies are hurting because of trying to keep up with health care. But if that does not get worse and we continue to grow the economy, we realize that we've got a lot of state employees that have been very, very patient and have been continuing to serve without raises. And we have been addressing some of the law enforcement and some of the public safety the last year, and we will continue doing that this year with some commitments that we made. And we know that corrections is going to be probably the next one we have to deal with. And so you've got our promise that we are not treating you like a foster stepchild. It's just that we're just doing what we can when we can.
That.
Okay.
And recall, too, that in 2008, the governor did recommend, this body did agree, and approve a pay raise, a starting salary to go from $24,332 to $27,471, I believe. It was passed, it was approved, and the bottom fell out. That pay raise went away. So it's been a decade.
Okay.
Thank you.
Okay. Any other questions or comments from members of the committee? Thank you, sir.
I do. Going right back to the same issue. We have approximately 8,000 officers. How many unfilled vacancies do we have right now trying to recruit to fill those vacancies?
Any given day across the state, probably, again, off the top of my head, I can get you an exact figure. 8,000, we're probably running 500 to 750 across the state of Georgia.
And you're actively recruiting, so it's
Absolutely. Now, what we're also doing, we're a paramilitary organization, like our colleagues at State Patrol. We are actively recruiting military veterans, and we're really pushing hard to get these men and women who have served our country and are coming back home to all the military bases across Georgia. We have implemented, it's been several years, Chairman Neal, implemented an incentive for former military people to come work for the Department of Corrections. Self-funded again. We are self-funding these. We will pay a man or a woman who has served up to 4 years active duty service in the United States military a 2.5% pay increase per year up to 4 years of active duty service to come work for the Department of Corrections. So if you are a 4-year veteran of the armed services and you come to work for us and instead of starting at $24,300, you're going to start 10% higher. So you're going to start at what, $26,700. It's a little bit of a help, but men and women of the military make great employees in a paramilitary organization. As a matter of fact, we will be at Fort Stewart April the 17th with our colleagues from State Patrol and GBI. We've all partnered in this, all law enforcement, DNR, to actively engage and recruit from the United States military. So any help that this body could potentially do in that area, helping our law enforcement agencies who are recruiting heavily from the military, we would appreciate that. And they make awfully good employees. And speaking as just one Georgian, one American, it's the right thing to do for these men and women who've served our country. I don't know if that would stimulate some thought, perhaps.
Anybody else? I'm going to editorialize a little bit on your behalf, Commissioner. Having served on post counsel for about 12 years, you see the effect of the $24,000 a year salary, too. A significant portion of the people that come before post counsel for disciplinary reasons come from the Department of Corrections. If you can't pay a decent salary, you don't get a decent employee, and I don't know how much that costs you in your system to investigate all those people, but I know it's pretty significant. And it affects the morale not only of your workforce, of the inmate population, too.
Absolutely. Thank you, sir.
Thank you for coming, and we'll look to talk to you about some of these other issues when we get to the 14th.
Thank you for your support,
Thank
sir.
you. This meeting is concluded.
I saw something on my calendar that said